Welcome to another lecture by MedicoMedics, Gonorrhea. In this lesson, we will begin with a general introduction of gonorrhea. We will talk about normal physiology and pathophysiology. Furthermore, we will present a small case example, talk symptoms, diagnoses, differential diagnoses, and treatment. We will end with a summary, and for our medical students, we recommend looking at our high-yield review. Now, gonorrhea is a common sexually transmitted infection, also known as an STI. It is caused by the bacterium Neisseria gonorrhoeae, which affects the mucous membranes of the genitals, the rectum, and the throat. If it's untreated, it can lead to severe health complications. Now, the causative agent is the bacterium Neisseria gonorrhoeae, and it is a gram-negative diplococcus, meaning it appears as paired spherical bacteria. And you can see it here illustrated. Now, its main transmission is through sexual contact, so it primarily spreads through vaginal, anal, or oral sex. It can also be transmitted from mother to baby during childbirth, leading to eye infections in newborns. Symptoms in men would be burning during urination, or the sensation of burning during urination, a white, yellow, or green discharge from the penis, and sometimes swollen testicles. In women, we will see increased vaginal discharge, painful urination, and lower abdominal pain. Symptoms are often mild or absent. Now let's look in greater detail at the pathophysiology of gonorrhea. So we have an infection by Neisseria gonorrhoeae. This bacteria attaches to cells of the mucous membranes in genitals, rectum, or throat using special structures called pili, which are hair-like projections. So when that has happened, we then have intracellular invasion. So gonorrhea invades cells of the mucous membranes and then multiplies, causing tissue damage and inflammation. Now we have evasion of the immune system. So there is antigenic variation. So the bacteria frequently change their surface proteins to avoid being recognized by immune cells. Furthermore, there is inhibition of immune responses. So the bacteria, gonorrhea, releases proteins that interfere with immune cell functions, making it harder for the body to clear the infection. So normally, you have an invader entering your body. There is an automatic immune response to it. We have our innate immune system, right? And we have our adaptive immune system, depending on past exposure. But we will normally see an immune response to it, whatever that invader is. However, as we mentioned here, and this is interesting because you can generalize it to a lot of different pathologies, and bacteria, viruses, etc., they have these characteristics of being able to evade our immune system. In this case, for example, this particular bacteria frequently changes their surface proteins, right? And that should tell you that our immune cells are trained somehow to identify proteins on its surface. And if it keeps changing it, at least our adaptive immune system will have trouble recognizing it. Furthermore, it releases proteins that interfere with immune cell functions. So it makes it, all in all, it makes it harder for our immune system to actually deal with this bacteria. However, upon recognition, we will still see the normal immune response to the infection, which leads to the process of inflammation. And inflammation then presents with symptoms like discharge, pain, and swelling. So if we compare normal versus pathological findings in gonorrhea, what do we see? Well, if we look at a healthy genitourinary tract, there should be no symptoms or discharge. There should be a normal tissue structure, and there should be no risk of infertility. But if we compare that to gonorrhea-infected genitourinary tract, we will see painful urination, discharge, and swelling, signs of inflammation. The normal tissue structure will have changed due to inflammation, cell damage, and tissue erosion. Furthermore, we will see a development of higher risk of infertility and pelvic inflammatory disease in women. So let's take a look at a typical case example for gonorrhea. So we have a patient, 25-year-old male. He's complaining of burning sensation during urination, thick yellow discharge from the penis, and mild testicular pain. Naturally, we ask him about his recent history, specifically sexual history, and he reports unprotected sexual contact with a new partner. We do our physical examination, and we do a genital exam, and we observe thick discharge from the urethra and mild tenderness in the testicles, all suggestive of gonorrhea infection. So how do we then properly diagnose gonorrhea? Well, we have a clinical presentation, as mentioned before, painful urination, discharge, all of it strongly suggests gonorrhea, especially in sexually active individuals. But what we then do is laboratory testing. So we can do a nucleic acid amplification test, or a NAT. This is the most accurate test for gonorrhea, detecting bacterial DNA in urine or swab samples. So when we do swab samples in women, we do a swab of the cervix or vaginal area. In men, we do a swab of the urethra. How do we go about doing a nucleic acid amplification test? Well, first we do a sample collection. So urine typically is the first catch for men, or we do a vaginal or endocervical or urethral swab for women. We can also do a rectal or pharyngeal swabs if it's indicated. We then prepare the sample, of course using proper sterile swabs, etc. We then do DNA extraction. So the sample we've taken undergo processing to isolate the bacterial DNA. We then use polymerase chain reaction, PCR, or transcription-mediated amplification, TMA, which will then increase bacterial DNA copies for detection. We then use fluorescent probes or specific markers to identify the specific DNA of Neisseria gonorrhoeae. We then look at the results, and if it's positive, well, then we have shown that there is a gonorrhea infection present. If it's negative, it means we haven't detected DNA, so the infection is unlikely. It's not impossible, but it's unlikely. And if we can't determine it, we will do repeated testing. So urine samples can also, as we just mentioned, detect gonorrhea in both men and women, actually, which provides us a non-invasive way of screening for gonorrhea. Now then, let's look at the differential diagnoses of gonorrhea. So if we, for example, look at chlamydia, it often co-occurs with gonorrhea, but presents with less purulent discharge. It also requires NAAT for confirmation. But if we look at, for example, bacterial vaginosis, which presents with a thin grayish discharge with a very characteristic fishy odor, this will clinically be done by the so-called whiff test, and we follow the AMSL criteria for diagnosing BV. Over time, you will be able to differentiate BV rather quickly from gonorrhea. But if you want to be specific and more accurate, looking in the microscope or underneath the microscope, you will identify clue cells in bacterial vaginosis. Furthermore, you will see a change in pH. Because if you've seen our lecture on bacterial vaginosis, you will know that there is, in the normal vaginal flora in women, we have a pH between 3.5 and 4.5, and this is maintained by the presence of lactobacilli. However, for whatever reason, the balance has been disrupted. The lactobacilli is not able to maintain this range of 3.5 to 4.5. And this allows for other bacteria to start multiplying and overgrow, leading to these characteristic symptoms of grayish discharge with a fishy odor, for example. Another very crucial thing to pick up on is pelvic inflammatory disease. So it is often caused by untreated gonorrhea or chlamydia. Presents typically with fever, abdominal pain, and cervical motion tenderness. What about herpes? So herpes presents with painful genital ulcers or vesicles, often with more systemic symptoms. And we confirm it by using a viral culture or PCR. So you see that there are a lot of similarities between these, but there are also very specific differences. And over time, as you become more experienced, you will learn how to clinically differentiate them rather quick. But it is highly recommended that you, first of all, study each of these individually, and then you proceed to differentiating between them. So once we've diagnosed gonorrhea, what do we do to treat it? Well, we have antibiotic therapy. We're dealing with a bacteria here. So we can use ceftriaxone, given as a single intramuscular injection, 500 milligrams. Ceftriaxone is actually the first-line treatment. What is the mechanism of action of ceftriaxone? Well, it's a cephalosporin antibiotic, so it belongs to the class of cephalosporins, and it interferes with bacterial cell wall synthesis, causing the bacteria to rupture and die. But as mentioned, chlamydia often co-occurs with gonorrhea, right? So if you face one, assume the other. So we can do dual therapy. Azithromycin or doxycycline may be added to cover potential co-infection with chlamydia. Another thing is to abstain from sexual contact, so patients should avoid sexual contact until treatment is complete to prevent spreading the infection to others. Of course, testing and treatment of partners. So if you do discover that you've been diagnosed with gonorrhea, sexual partners that you've had contact with should also be tested and treated to prevent reinfection and further spread. Some additional considerations and prevention. So safe sexual practices. Consistent use of condoms greatly reduces the risk of gonorrhea transmission. Routine STI screening. Regular testing helps detect gonorrhea early, especially for sexually active individuals under 25 or those with new partners. And of course, partner notification and treatment. So informing and treating partners prevents reinfection and reduces the spread of gonorrhea. So in summary then, gonorrhea is a common STI caused by the bacterium Neisseria gonorrhoeae. Often presents with symptoms of painful urination and discharge. The bacteria, gonorrhea, attaches to mucous membranes. It invades our cells and evades our immune defenses, leading to inflammation and symptoms. We diagnose it with NAT testing, which we do on urine or swab samples, which is the gold standard for detecting gonorrhea. We treat it with ceftriaxone injection. Often we pair it with azithromycin or doxycycline to cover possible co-infection with chlamydia. And here is our high-yield review of gonorrhea. We recommend especially medical students to stop here and repeat. And that's the end of the lecture. Thank you for listening. If you liked our video, please like and subscribe for more videos.